Hi guys. So today we're going to start going over chapter 44, which is pathology of the ovaries. And I feel like this is probably the most difficult chapter that we're going to go over this semester from the fact that there's just so much information. So we'll be splitting it into 2 weeks again. So let's get started. So we've kind of talked a little bit about the ovaries, but again, to just kind of review, they're usually paired shaped almond structures situated on each side of the uterus, close to the lateral pelvic wall, and the ovarian ligament holds them in place. They can be variable in position, especially if there's been a pregnancy, just because the ligaments have been stretched out. And just everybody's a little bit different. And that's what you'll learn when you guys start scanning yourselves too, that everybody's ovaries are in different spots. They're not exactly just in the same spot. Most of the time, in a perfect uterus and ovary, you're going to have an anti-flex midline uterus, and then the ovaries are just going to be identified laterally. And if you get lucky enough, that they're pretty easy to see that way. So this is just a picture of the anatomy of the ovaries. You can see the ovarian ligament attached to the uterus, holding the ovary in place. This ovarian ligament is important because when you think about, you want the fallopian tube to be close to the ovary when it comes to fertilization. So that's why the ovarian ligaments are pretty important. So when the uterus lies to one side of midline, so the right or the left, which can happen, the other ovary is usually found superior to the uterine fundus. So if you have a uterus that lies more to the right ovary is potentially going to be on top, or like kind of laying superior to the fundus. And I see that quite a bit too. So the retroverted uterus, the ovaries tend to be more near the fundus of the uterus. So looking towards the fundus is going to be your best bet when it comes to retroverted uteruses. And when the uterus is enlarged, they usually are displaced more superiorly and laterally. Usually following a hysterectomy, a lot of the surgeons will kind of put the ovaries, tie them close to the medial and directly superior to the vaginal cuff so they're easy to see. But if that doesn't happen, they can kind of get lost a little bit, and they can be located high in the pelvis or in the cul-de-sac, and that's difficult to see transvaginally just because they would be out of the field of view. So a lot of the times when this happens, I might have to do a transabdominal ultrasound too and look more laterally right and left just to see if I can see the ovaries. And a lot of the times they've just kind of traveled up higher in the abdomen or in the pelvis. They are anterior cauded to the internal iliac vessel, which is going to be your landmark. If you go past when you're scanning and you see the internal iliac vessels, the vein and the artery, but you haven't seen the ovary, most of the time, that's going to be your signal that you can't go any further. They should be more midline than that. So they're mostly homogeneous. They have small anechoic cystic follicles, which you've identified one of those on your test. And their appearance varies with age and menstrual cycle. Here is an image of 2 ovaries in the uterus. These ovaries are pretty close to the uterus, so those would be pretty easy to see. This is another ovary, a really pretty nice ovary. Transvaginally, they're just so much easier to see than transabdominally. Here's another picture. And you can see this vascular flow. That's normal vascular flow within the ovary. And one more. So you will measure the ovaries in 3 planes: sagittal, transverse, and your height, your AP diameter. and that'll give you a volume for the ovaries. And we went over this a lot, like earlier on with the stages of both the ovary and the menstrual phases. But let's talk about it one more time. This is like the life cycle of a while a patient is fertile. So you can see the menopausal atrophied ovary. They're in retirement and they don't need to work as hard anymore, so they usually shrink up, and there's definitely not as many follicles seen on the ovaries. Prepubertal, before they have gone through puberty, they're going to be smaller too, with just a couple of little follicles. So menstruating ovary, let's start there. And you can see that right here, there was just a little follicle here. So this is when a period is, or a patient is on their period, their menstrual phase, day 1 to 5. This is the before the proliferative phase. This, though, is all the follicular phase of the ovary. So then it develops into a dominant follicle, and you can see that it gets larger. It's beat out all the other follicles for the dominant spot. Then a patient ovulates. This is going to be the luteal phase. It develops into a corpus luteum. If the ovary doesn't get the signal that there has been pregnancy, it degenerates, and then it starts over again. So these two are the follicular phase, these two are the luteal phase. Now, if a patient does become pregnant, the corpus luteum is going to get larger and stay for the first 12 weeks. So what I want you to know about this slide is during the early proliferative phase, many follicles develop and increase in size until about day 8 or 9. And this occurs because of the follicle stimulating hormone and the luteinizing hormone. If you remember, we talked about that in a couple chapters ago. But at this time, one follicle becomes dominant and it reaches, this is for your test, 2 to 2.5 centimeters at the time of ovulation. The rest of the ovaries kind of die down, or follicles die down. That's not their time. But there's one that reaches the peak, and it's the one that's going to be ready for ovulation. So if you scan yourself in your normal cycles and you see a dominant follicle around 2 to 2.5, that's totally normal, just a simple cyst, and you're probably getting close to ovulation. Sometimes you can see the cumulus oophoris, and it's like a little cyst-like area that is seen in the dominant follicle. And that just means that ovulation is about to occur. So follicular cyst develops if fluid in non-dominant follicles are not reabsorbed. And dominant follicle usually disappears immediately after rupture. Sometimes it kind of can look like a little scrunched up version of itself for a second before it turns into the corpus luteum. This is when you can see some fluid in the cul-de-sac during this time. It's pretty normal to see some fluid after ovulation. So following ovulation in the luteal phase, the mature corpus luteum develops, and may be identified sonographically as a small hypoechoic or isoechoic structure. So it no longer appears cystic, it more is like a hypoechoic structure. Less frequent, sometimes you see the typical ring color, so that ring of fire. So when you put Doppler on it, it's gonna light up. But if fertilization does not occur, the corpus luteum begins to undergo changes and disappears right before menstruation. Sometimes you'll see multiple small punctuate echogenic foci in the ovary. They're usually really small, they don't shadow. But sometimes with menopause, these become increasing. And menopausal ovaries are very, very hard to see. So you're going to get a patient that comes in for postmenopausal bleeding. And what they're really wanting to see is the endometrium, see the endometrial lining, but you always want to try to check for the ovaries. And a lot of the times they become so small in a trophy that you can barely see them. There's been a lot of times that I've had to say right or left ovary not visualized. The other thing that makes it difficult is there's no follicles. So you don't have that to kind of help you out. Again, after hysterectomy, the ovaries can be difficult to visualize with ultrasound, and use both trans-abdominal and transvaginal approaches increase chance of visualization, just like I said. Okay, another thing that for your test, a normal ovary has about a volume of 9.8. So you guys should take a look at your own and see how close you are to that. The volume is taken after the length, the height, and the width is measured. I mean, it's plus or minus 5.8. So if it's not right on, it's okay, but around that area, around 10. A volume of more than 8 cc's is definitely considered abnormal in a postmenopausal patient. So if you think about it, normal ovaries in postmenopausal should be atrophied. If you see one that is almost looks about the same as a patient that's not gone through menopause, there could be some potential of something going on, like malignancy or such. The other thing is a volume of more than twice that of the opposite side should always consider normal. So you have your right ovary is a normal 9.8, but the left ovary has a volume of, like, let's say 20. And that's cause for concern because they are not close together. So that would be something that they would want to follow up on. Okay, so one thing that you're really going to see the most are simple cystic masses. They're the most common thing that you're going to see. They can cause pain. People cannot know that they're there. But I think when you're scanning, this is going to be the most common. So the ovary function is to mature oocytes until ovulation under influence of LH hormone, which is the happy face hormone, if you remember, and follicle stimulating hormone from the pituitary. At the same time, the ovary synthesizes androgens and converts them to estrogens. So the ovaries are also responsible for our female characteristics. Finally, produces progesterone after ovulation to sustain the pregnancy. How it does that is the corpus luteum helps to produce that. Usually only one follicle enlarges from 3 millimeters to 24 millimeters over about the 10 days. So about 2.4 centimeters is where you want it before ovulation. And the ovulation occurs, then the corpus luteum or abnormal unruptured follicle can persist as a simple or complex cystic structure. If a cyst is greater than 6 centimeters and persists for more than 8 weeks, surgical intervention may be considered. So they don't really like to do anything with simple cysts until they're greater than 6 millimeters. So I've even done some needle aspirations with some doctors where they'll go in and just drain the fluid from the cyst if it's simple. Now, if you remember what our simple cysts look like, are just anechoic, thin-walled, acoustic enhancement. A majority of the ovarian masses are simple cysts, and most of those are benign. Almost all of them are benign. So that's what you're going to see the most. And most of the time, they're going to be just benign cysts. But they can cause pain, so it's something that we need to mention in our report. Hey, look at that. Just what I said. Thin, smooth wall, anechoic contents, acoustic enhancement. Those are your criteria for a simple cyst. There is a simple cyst in the large adnexa. This would definitely be something that you would want to mention, but it doesn't have any internal contacts, and it wouldn't have any vascular flow, so it's probably benign. Sometimes you'll see small anechoic cysts in the postmenopausal ovary, but they're a little bit more concerned with these with postmenopausal ladies just because they have a higher chance of ovarian cancer. So a lot of times if there is a cyst, we will scan multiple times throughout the months to see if it changes. And surgery is generally recommended for postmenopausal cysts greater than 5 centimeters, or those that are containing internal septations or solid nodules. So these are the most common cystic or complex ovarian masses that you're going to see. First, just a regular follicular cyst, a corpus luteum cyst of pregnancy, a cystic teratoma, a para-ovarian cyst, a hydrosalpinx, endometrioma, or hemorrhagic cyst. So anytime a simple cyst hemorrhages, it becomes a complex mass because it starts bleeding into itself. So you're going to see not your simple cyst anymore, but more of a complex cyst with internal echoes. This is probably a simple cyst gone bad or hemorrhagic cyst. So you can see that this internal, it's no longer anechoic and nice and smooth and black. It's more irregular with internal echoes. This is probably just a cyst that's hemorrhaged and probably caused the patient pain. These are your common complex masses, and we'll talk more about these next lecture too, but cystadenoma, dermoid cyst, tubo-ovarian abscess, ectopic pregnancy, and granulosa cell tumor. Mixed solid to cystic ovarian masses, typically epithelial ovarian tumors, and the most common are the cystadenoma and the cystadenocarcinoma. Again, these happen during the fertile years. 1 in 15 are malignant, but we will again address these later on. This is a dermoid cyst, which we'll talk about next chapter 2, but I just want you to look at it and see that it's just like the borders are ill-defined and you almost could miss it, right? And that's just how those dermoid cysts appear. They almost appear like bowel gas, but they ended up being just a dermoid, which is usually just a benign thing, but something that needs to be removed if causing patient pain. So our rule generally is more sonographically complex the tumor, the more likely to be malignant, especially if it's associated with ascites. So I want you to remember that. So if you see this more simple thing is, the more likely it is to be benign. Epithelial serous tumors are the most common. And 1/4 can be bilateral, but again, we'll talk about these. We'll address these later on. What I do want you to know for this part is the ovary with a volume twice that of the opposite side is generally considered abnormal. When a solid mass is found, care taken to identify connection with uterus to differentiate ovarian lesion versus pedunculated fibroid. Now, this is something that can be just very difficult if you don't exactly know, if you're still kind of learning. The pedunculated ovaries or fibroids can almost resemble ovaries because there's a stalk coming off the ovary that kind of looks like the ligament, the ovarian ligament. The difference that I can see is just in the ovarian tissue is more smooth, while the uterine tissue, and especially of those of fibroids, is more heterogeneous and not very pretty. But this is just something that takes practice to identify the difference, but something to be aware of. Color Doppler can be helpful by using color to identify vascular pedicle between the uterus and the mass, as can be identified with pedunculation. So one thing that you could do is put color on, and most of the time the stalker, the pedicle from where the uterus is connecting with the mass, is going to light up with color, and that'll help identify that, yes, this could be more of a pedunculated fibroid than ovarian mass. These are other common solid masses that we will address later. Let's talk a little bit about Doppler. I don't want you to spend too much time on this just because there's other things that are more important, but there are a couple key things with Doppler of the ovary that I want you to know. We like to do a Doppler of the ovary for almost every time. I mean, I always put color on, especially if there's a cystic lesion or torsion is expected. This is what the vasculature of the ovary looks like. So it is kind of pretty vascular. We like to Doppler the flow, the artery, ovarian artery, and the ovarian vein. Patients with normal menstrual cycles best scanned in the first 10 days. And this avoids confusion with normal changes in the intra-ovarian blood flow because of high diastolic flow occurs in the luteal phase. Okay, so what that means is, let's see, I want you to know that for malignancy, if there is some kind of cancer, usually the ovary has like a high resistance flow. And we kind of talked about this a little bit, where it's going to have a high systolic, low diastolic flow in a normal ovary. But when there's malignancy or ovarian malignancy, or even during the luteal phase when the corpus luteum wants more blood flow, what happens is it becomes a low resistance flow. So that's going to be a lower systolic, higher diastolic flow. So you're going to see multiple vessels during malignancy, low resistance flow, and the absence of the normal diastolic notch in the Doppler waveform. So it's just going to be more of a continuous flow instead of our high resistance that we usually see in an ovary. So abnormal waveforms can be seen, and when they say abnormal, that usually means that lower resistance flow can be seen in inflammatory masses, metabolic active masses, and corpus luteal cyst. The one that I want you to look at here, pulsatility index, is calculated by the peak systolic velocity minus the end diastolic velocity divided by the mean velocity. And some people use this, but a lot of the places I know use the resistive index, and that's the peak systolic velocity minus the end diastolic velocity divided by the peak systolic velocity. Now, don't be afraid. You don't have to calculate this, the computer does, but you do want to know what it is, the RI. So what that would mean would be a lower RI would be increased risk for malignancy. So increased diastolic flow suggests neovascularity and the likelihood of malignancy. The cutoff values for the PI is usually 1 and the value RI is 0.4. So if it is lower than that, then it has a higher chance of being malignancy, because the lower the RI, the higher, or the lower the resistance. The higher the RI, the higher the resistance. So a mass showing complete absence or minimal diastolic flow is usually benign. And that's what I want you to take away from this. When you see more diastolic flow, it has a higher chance of being malignant. In the first 7 days, the flow to the ovaries has the greatest resistance with the lowest diastolic flow. And that makes kind of sense, right? Because as you go through the cycle, the ovarian cycle, the it's going to need more blood flow to help develop the follicle and the corpus luteum. So it creates a lower resistance flow in the later part of the cycle. So later in each cycle, the diastolic flow increases, particularly in the dominant ovary. All right, so let's talk about functional ovarian cysts. Functional cysts result from normal function of ovary. Most common cause of ovarian enlargement in young women, functional cysts can be follicular, corpus luteum, hemorrhagic, or theca-lutein cysts. They're benign. Hormone therapy, sometimes administered to suppress cysts. That means OCPs or birth control. Most cysts measure less than 5 centimeters and regress during the subsequent menstrual cycle. So let's say we're going to scan someone. They've been having pain on the right side and you see like a 4 centimeter simple cyst. You would mention that. What they're going to do is probably follow up within a couple of weeks, probably months, to see if it's resolved. And most of the time it resolves and nothing else is needed to do. Sometimes, however, the cyst becomes larger or causing more problems. And in that case, that's when surgical intervention might be needed. So why do we get follicular cyst? And it occurs when the dominant follicle does not succeed in ovulating and remains active, though mature. So it didn't do its job, so it never ruptured, and it just gets bigger and bigger. And it may grow up to 1 to 8 but they're centimeters, but they're thin-walled, translucent, have watery fluid. And a lot of the times they just disappear on their own when they're ready. This is the clinical symptoms that I want you to know about a follicular cyst. They're usually asymptomatic to dual adnexal pressure and pain. Torsion may result in severe pain, which we'll talk about, but the sono findings are simple cyst. So a corpus luteal cyst results from the hemorrhage within the persistently mature corpus luteum, and it's filled with blood and cystic fluid. It may grow up to 1 to 10 centimeters in size and may accompany intrauterine pregnancy. Clinically, it's going to be irregular menstrual cycles, pain, mimic ectopic pregnancy, and rupture. Sono findings: cystic type of lesion may have internal echoes secondary to hemorrhage or increased color. So these, when a patient gets pregnant, sometimes they can get these cysts. And so we would want to note that and make sure that that goes away. This is what a corpus luteal cyst looks like. It has some hemorrhage in it. This is the blood. So a hemorrhagic cyst, these are the ones that I feel like the patients come in with the most pain. A lot of the times they don't come in like from the simple cyst as much as the hemorrhagic cyst. So internal hemorrhage may occur in follicular cyst or more commonly in corpus luteal cyst. And patient may present with acute onset of pelvic pain. This is a hemorrhagic cyst. You can see that it is just a solid mass more with internal echoes. A lot of the times when you put color flow, you're going to see lots of vascular flow around the periphery of the cyst, and that's called the ring of fire. So acute hemorrhagic cysts, which mean they've just happened, occur more hyperechoic and may mimic solid masses. As the cyst advances in its age, the internal patterns become more complex. Theca-lutein cysts are large bilateral multiloculid cysts and are associated with high levels of HCG. So if patient gets pregnant and they have lots of HCG, they have a higher chance or have a molar pregnancy, trophoblastic disease. They have a higher chance of having these theca-lutein cysts, which there are multilocular cysts seen on both ovaries, and they're bilateral most of the time. This is large cyst seen in the ovary. Ovarian hypostimulation syndrome is a frequent complication of ovulation induction. So when a patient's doing fertility treatments, they're stimulating those ovaries beyond what they would normally do. And a lot of the times they try to get as many follicles as they can. So they're going to try to stimulate the ovaries. This can cause the patient to have pelvic discomfort, and the ovaries become very, very enlarged. But they're trying, what their goal is let's get as many little mature follicles as we can to retrieve for the fertility treatments. Sometimes with severe hyperstimulation, if they get too hyperstimulated, patient has severe pelvic pain, abdominal distension, and the ovaries are greater than 10 centimeters. This actually can cause ascites and pleural effusions. So this is kind of dangerous. So the doctors that do the fertility treatments watch out for this. Most of the time this is treated. When treated, the condition usually resolves within 2 to 3 weeks. Now, one of the main things I want us to look at today are polycystic ovarian syndrome. You need to know this. Probably one of the most important things for you to know. And it includes Stein-Leventhal syndrome. And what happens is it's bilaterally enlarged polycystic ovaries. It occurs in the late teens through the 20s, and a patient may have endocrine imbalance. I'm sure you guys have heard of it. It's pretty common syndrome, actually. And the spectrum of sonographic appearances. So clinically, a patient is going to not have periods very often because their ovaries aren't functioning correctly. So they're going to have amenorrhea. A lot of the times these patients are obese. They can't get pregnant. They have difficult infertility. They have infertility because, again, they're not ovulating. Hirsutism, I'm horrible at saying that word, but that's abnormal hair growth on the face, chest. Sonographic findings, multiple tiny cysts around the periphery of the ovary. Ovary may be normal or size or enlarged. We call this that pearl of, or string of pearls sign. And you're going to see these a lot of the times with polycystic ovarian syndrome. I've seen that the ovaries are a lot more round. So you're used to, like in a normal ovary, they have more of an almond shape. But in the polycystic ovarian syndrome, they're going to be more round. They're going to be larger in volume, and they're going to have a lot of cysts. And then the patient is going to have those clinical symptoms at the same time. And that really hints you off that this could be PCOS. Peritoneal inclusion cysts, they are just adnexal cysts that aren't exactly connected to the ovary, but kind of just in the adnexa. And most of the time, they don't cause any pain. Now, this is a very large cyst. A lot of the times what you're going to see are not these as large. You're just going to see a little cyst out in the adnexal area, and you're like, okay, well, it's not connected to the ovary. What could it be? You can have a peritoneal inclusion cyst. So it's just a cyst that's within the peritoneum. These are really large. You would definitely want to mention this large cyst. Para-ovarian cysts, they're usually simple and complete or torus, and they're from the Wolffian duct remnants. So they're also a cyst that's not quite on the ovary, but located in the broad ligament. So you're going to see these kind of cysts just kind of close to the ovary, but not necessarily straight on the ovary. So what you'll see is a simple cyst adjacent to the ovary. And this is what it is, a para-ovarian cyst. Again, this is a very large para-ovarian cyst, something that would be mentioned. Okay, endometriosis. Endometriosis is a common condition which functioning endometrial tissue is present outside the uterus. We kind of talked about this a little bit. A lot of people think that it's from retrograde flow going through the endometrial canal into the fallopian tubes, and that blood goes into the adnexal areas and endometrial implants occur that way. But ectopic tissue can be found anywhere in the pelvis, including ovary, fallopian tube, broad ligaments, external surface of the uterus, scattered over the peritoneum, cul-de-sac, and even the bladder. So these patients that have endometriosis, when they have their periods, have very severe pain, because not only is the uterus contracting, this tissue is also contracting. So let's think about that. If you had this endometrial tissue that was on your bladder or like on your rectum, you know, that's why like the cramps are so severe with these poor patients. The endometrial tissue cyclically bleeds and proliferates, and diffuse form leads to disorganization of pelvic anatomy and appearance of similar to PID or chronic ectopic pregnancy. So it kind of looks the same as just like an infection, yet it's not. Two forms of the endometriosis are described. It's the diffuse and localized endometrioma. So with the diffuse tissue, we can't see that very well on ultrasound. It's more difficult to see for sure. Diffuse form is more common and consists of endometrial planings within the peritoneum. So when a patient has endometriosis, a lot of the times the best way to confirm this is to do like a laparoscopic surgery. It's rarely diagnosed by sonography. Where we can help with endometriosis is when it comes to the localized form, and it consists of a discrete mass called an endometrioma or a chocolate cyst. And the reason that it's called a chocolate cyst is when it's cut into, the blood is brown, which is nice and gross, and it's frequently found in multiple sites. To be honest, I think that endometriosis is like an endometrioma is just, for some reason, it's just appealing to my eye. I don't know how else to say it. And I think it's because it just has this ground glass appearance. It's just hypoechoic. And let me see. So it's just this, if you see like something like this, like with just a, just, it's uniform, yet it's hypoechoic. So it's not like a heterogeneous, but this is what an endometrioma looks like. And on our discussion board, I'll put some more pictures of endometriomas because you'll have to be able to identify those for your test. It contains diffuse, homogeneous, low-level internal echoes. So if you get a question about your test, what kind of mass contains diffuse, homogeneous, low-level echoes, it's an endometrioma. Here's another one, although I don't think this one is as pretty. Ovarian torsion is the last thing we're going to talk about before we're done today, and it is caused by partial complete rotation of the ovarian pedicle on its axis. So if you can imagine, this would be a very, 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 very painful situation. These patients can barely walk, let alone get on the table. So a lot of the times this is diagnosed clinically. But if you were to scan a patient with ovarian torsion, what happens is once there's not as much blood flow, it becomes a swollen ovary and is usually greater than 4 centimeters in diameter, so it becomes pretty big. If you're going to see multiple tiny follicles around the hypoechoic mass, a completely solid adnexal mass, and free fluid is often present in the pelvis, then you have the clinical symptoms of a patient in severe pain. Then the Doppler exam reveals absent flow, which is going to be your big thing, because if you guys can remember from earlier on in the lecture, the vascular flow is quite impressive within the ovary. So when you're not seeing any, that should hint you off, and a large ovary hint you off that potentially torsion can be suspected. It accounts for 3% of the gynecological operative emergencies, acute abdominal condition requiring prompt diagnosis and surgical intervention. So they got to do it pretty fast. Sometimes they can't save the ovary. Causes edema and eventual loss of arterial perfusion with subsequent infarct. And torsion typically involves not only the ovary, but also the fallopian tube. So it's a pretty severe thing. The other scary thing is once torsion has occurred, you have a 10% chance increased incidence of it occurring on the other side. Most of the time, the torsion occurs in children and younger females. A lot of times they'll have an ovarian cyst or mass or pregnancy. So here are your sonographic findings usually associated with mass: hypoechoic enlarged ovary with peripheral follicles, absent blood flow is a huge one. These two are the biggest: free fluid and cul-de-sac, and it's a surgical emergency. Clinically acute severe unilateral pain. Symptoms mimic other things. One of the other things that could be a differential consideration would be appendicitis, especially if it's on the right side. Patient may have fever, nausea, and vomiting. And usually a palpable mass is felt because the ovary is so huge. The other thing that I want you to know is the right ovary is 3 times more likely to torse than the left. So torus ovary is typically enlarged and heterogeneous in appearance, owing to edema, hemorrhage, or necrosis, and is often pretty easy to see, the ones I've seen. Okay, here's the ovary here. It just doesn't look pretty anymore. And then you have like a cystic mass, which is probably the cause of the torsion. Torus masses are often large, greater than 4 centimeters. Palpable mass may be present, and torsion occurs more frequently on the right side. Okay, I think that's it, guys. That's all I want to talk to you about today, and we'll go over the rest of the slides next week. All right, have a good day. Thanks.